Aí os outros ficam olhando, tem. Ou é longe.
Ah, ele fechou. Não, ele pôs o dele e aí...
Mas a gente vai precisar botar o do professor Girolamo.
Foi o Caetano que botou aí?
Se quiser usar o adaptador.
Olá, tudo bem? Tudo legal. Oi, tudo bem?
Deu tudo certo.
Não é meu, esse aqui é da live. Oi?
I got it. This is mine. No problem. It's great.
Eu já
Good afternoon, everyone. Welcome to Federal University of São Paulo, Paulista School of Medicine in our Pediatric Trachea Masterclass. We would like to say thank you, everyone, to join us today, both those here with us in person and those watching online. We hope we all have an enjoyable and inspiring afternoon. Before we begin, I would like to make a few brief announcements. I would like to say thank you to Professor Saad, to Professor Fábio Marioni, boss of endoscopy of Santa Casa de Misericórdia, Professor Fernando Herbella, gastrosurgery, and Professor Ramiro Coriani. So our program will start with a 40-minute lecture followed by a 20-minute clinical case presentation. After these presentations, we will have an interactive discussion with our experts to explore the key topics in a greater depth. It is my great pleasure to welcome Professor Girolamo Matiolli, an internationally recognized pediatric surgeon from Italy. Today, Professor Matiolli will share his experience with robotic tracheotexia. Professor Matiolli, welcome. The stage is yours.
Thank you so much. I come from Italy. First time I was in Brazil, so I'm really impressed for many things. Next, when I am home, so you cannot get fighting me. I'm try to convince you that thoracoscopic approach in children is better than open, and is better than minimal access one, standard one. I'm full professor of surgery. I was training by adult surgeons in general surgery and in adult urology. And then I moved to pediatric surgery and full trained pediatric surgery. So I needed 15 years to get a standard in children, because I think that adult surgeon must know better than pediatric surgery. So I think training is mandatory. I'm professor of surgery. I'm a chairman of a pediatric surgery fellowship and the residency program. So I invite you to collaborate also for teaching and education program in children's surgery. I work at the Gaslini Institute, is the only children's hospital. We have an obstetric, but only for difficult cases. These are our number. And I'm director of the Department of Surgery. So I chair all the fields of pediatric surgery, neurosurgery, spinal surgery, trauma, and so on. So I will focus you about my personal experience in robotics, and these are my curriculum vitae, and these are my numbers at the Gaslini, and these are the numbers in other hospital where I work with, and we publish together. So now I did more than 700 cases in children. I say children, but I operate also young adults like 40 kilogram, 30 kilogram in neurologic impaired children that are any age, or are in transplanted kidney patients that are very difficult. And these are my curriculum vitae publication about robotics. Last one, 2026 for Hirschsprung, and many others. And the first one is this one about assessment in a pediatric hospital. So this was my general director, and we decided to start with the program together because obviously the robot was very costly. So we needed to start with a prospective trial that could be useful for the minister to let us work and paid by them. We began our experience with charities with donation, and now we are full paid by the minister. These are my certification. Thank you, campus doctor. First time I was in Brazil, was in Brasilia, sorry, and a few weeks ago, and I was involved in these chapters. Thank you. Everything I'm going to show you was allowed by our hospital. We are Joint Commission International Certificate Hospital, so we have a lot of restriction. Also, we are educational hospital and research hospital, so we have to follow strict route, and particularly with the regional ethic committee. And everything I'm showing you has been published, and before publication has been allowed by ethic committee organization. In the first period, these were our numbers. So you see number of procedures, thoracic. In the first period, 3, nothing. Robotically, not open, not thoracoscopically. And in the second period, 36. So it's very limited area. So I can finish, I think. About thoracoscopic surgery, robotically, only robotically, you see 18 tracheopexy and minimal area other procedures. Very few diaphragmatic hernia. Age, 6 months, we cannot face with TF repair robotically, probably. Weight, 6 kilogram. I think it's very difficult to enter with a robot in a 6 kilogram patient, but we did it. But absurd or not. I included in chest surgery only the benign one, and here you see the cancer one, neurogenic tumors, different chapter, but I'm the same surgeon, so this is my experience. Near 50 in the thorax, sorry. You see the numbers. So you can understand what we did in our hospital, GI tract. This is previous period, and these are my personal collaboration with other hospitals in Italy. Limits, I don't want now to speak about limits because in the chest you have more limits than in the abdomen. So these are our limits in abdomen. Why are we speaking about chest surgery? I will focus on tracheomalacia later. So this is my hands in a TF repair patient. 2 kilogram, 3 kilogram is not important. This is our standard. So we do thoracoscopic esophageal repair, fistula ligation, and anastomosis in this way. This is for me the standard. I do open surgery, yes, obviously, in unstable neonates like heart disorder, brain disorder, or in very low weight, under 1 kilogram, or when you need high frequency ventilation, for instance, for diaphragmatic hernia. And then we have to decide if we can do primary anastomosis or close the fistula and stop, because the anesthesiologist cannot keep the patient stable. So we wait. Why do you do this thoracoscopically? Because it's better for the patient and it's better for the staff. You see exactly what the surgeon is doing, and we know that through a thoracotomy, you don't see anything. And you see the vagal nerve. We know that post-atresia repair, you have a lot of motility disorder because you break the vagal nerve. But here you see very well, so we don't burn anything. Other aspect is after standard thoracotomy, you can have bridges and calcification between ribs. So I think that if you cannot do thoracotomy, it's better for the patient. So when we can, we do thoracoscopy. But the thoracoscopy is very difficult. So we need a learning curve. And the learning curve in TF repair is not so fast. So minimal access surgery in the chest is very infrequent in many hospitals. So we think they have to be collected. The problem is that, for instance, in TF repair is an emergency, and it's very difficult to transfer the patient. So there is a lot of debate on indication on emergency thoracoscopy. I move on. In China, they published this compare non-randomized but prospective study, and you see here 167 cases, randomization 155, and two groups, similar 63, thoracoscopic versus robotic, TF repair. So someone says that can be done. I'm skeptic. I want to see, I don't believe it to anyone. I want to see how they cook in the kitchen, and then after I say if the food was good. So this is my way to work. The reason why I'm here. So I show you, and then after we decide. I know that they, I don't know how to say, shorten the ports. So they cut the port to let them shorter. And this is impossible in our country because you damage the machine. So in September, I will go in Shanghai, and I want to enter in the operating theater and see what they did. I'm very interested, but they published this. Is evidence-based medicine. So we can do it. I don't know. When I show you this, then after I move to thoracic surgery. When my directors speak about money, and if money comes before ethic, I got this picture. These are three children that I had with me in Baghdad. I spent some period in Baghdad at the end of the Second War, and to get the car, they put benzene, petrol in the car and flame, so people get out. And these are three children. This was a bomb, and this was what happened. Obviously died, and this is, in my opinion, what is money first. So with my general director, I said, money first, the less costly is the death. So don't speak about money first. Ethic first. Less costly, but ethic first. So this is my point of view. And this is my nurse when I was in Baghdad in 2003. So this was my learning curve. I collaborate a lot with other countries. This is Haiti. I spent 2 years in Haiti, because I enjoy. This is Angola, in Luanda, and so and so. And Kazakhstan. My experience in trachea and the esophagus, mainly esophagus. In our department, we have a program of trachea surgery, so I work with the trachea team, and I'm more involved in robotic and esophagus, but also trachea because I enjoy it. So these are numbers. I don't want to bore you. I show this again video because this is my stupid day. This is the spleen area, a node sample. My chief on my back, I don't remember that when it started, said, go faster, cut it, go, harmonic. And there was the spleen artery on the back. So this is my starting in my experience. Don't do stupid things, always. So learning curve before starting with the stupid. So I want to show you me from the beginning. This is again stupid because I clip somewhere. So don't forget that there is a learning curve, and we must go, we must see, we must learn. Also, when we are full trained surgeons, the stupid day, this is my stupid day, can come every time. And stupid day, stupid day. So I open, grab the aorta, close the aorta with your hand, and go on. The patient was good. This was a lymphoma that was infiltrating the spleen artery, and there was a kink. I was stupid. So I started with this. About learning curve, robotics is very easy because you have a machine that can help you. So I think everything. You need 2 cases. If you are full trained open surgeon, you fix in a ureter. I'm sure 2 cases. You learn how to use the machine, you enter in the patient, and you do it if you are full trained. So I suggest to get the robot. Okay, but there are difficult cases. This is a stenosis of the trachea. This is a child who underwent ECMO, extracorporeal membrane oxygenation. You have here a porcine lobe. This is the operating theater during the procedure that is very crowded because anesthesiologists, nurses. This is the position of the patient near lateral 90 degrees. Position of the let you see my hands. This is a porcine lung. I am sure that compared with adult thoracic surgery, children are easier because this is not cancer. So I'm sure that an adult thoracic surgeon can do this procedure better than me. So I let you see some cases, very few cases. Out of 700 cases, I did less than 100 thoracic. And you see that the pedicle, vascular pedicle and the bronchus are very thin. So for you that are used to big tissue, bloody area, is so easy. But I let you see my experience. This is the bronchus, and you see the trachea. This is a porcine trachea. You know that the rings are complete, so you have membrane on the back and cannot breathe. So we decided with our pulmonologist to do a resection of the trachea. So as leave anastomosis was short for this patient, and so we did a standard resection. So you see, this is the carina. We do resection, and we decide that leave is sufficient. So resection of the trachea under ECMO, obviously, it's not breathing. And then we try not to do destroy vascularization, but some mobilization we need. We reach the carina, and the anesthesia low enough to understand where is the carina. Then we do first standard anastomosis. So, which is the difference with adult thoracic surgery? Completely different tissue and size of the patient, and no indication. Before this procedure, we saw adult thoracic surgeon how they do thoracic resection using robot. And this is another example of a trachea after open esophageal anastomosis because of atresia. The previous surgeon left a remnant of foregut, we call esophagus or fistula, and the patient developed many symptoms, and the risk of aspiration was very high, and also breath stopped. So we decided to operate, and that is the diverticula. You can reach the diverticula from the trachea. You open the trachea in front and in back, or from the chest. This is your choice. The patient is trachea ventilation, extracorporeal oxygenation, and then the endoscopist say yes, that's the place, and then we close it. So this is my experience. I don't speak about the lung, and so now I go to tracheopexy. This is a video. I hope you can see. Okay, this is a video you can see. So we start with the. This is not a video. Sorry, bad quality. I let you see another one. Yes, because of internet filters. Okay, this is another video. You see better. We open the azygous arch. We found the esophagus. We clean the esophagus. We grab and mobilize the esophagus because we want to get the membranous area to the spina. We are afraid of handling the esophagus with the graspers, so we put something to handle it. And then endoscopists say us, where is the bronchus? And then we see the aorta, but easy to understand where is it. And then we separate the esophagus from the trachea until the neck. We can reach easily the neck from this foot. This is a 3-year-old, 15 kilograms. Is big. So we have enough space. So we have to mobilize all the esophagus. Pay attention to supra-aortic branches. We try not to crack much because we are afraid to denervate, but we have to do it. If we do not mobilize, we cannot stabilize the spine. This kind of procedure you can do primary in TF repair. When you have a neonate, you can fix the esophagus in the same time you fix the trachea to the spine. This is an opinion. We prefer to do if they develop symptoms. You see the aorta on the back, very nice place. We know that gas creates the brain very easily, so you see everything. And this is the spina and the aorta. We feel the spina. You see here the spina. We create orientation. We traumatize the spina. Then endoscopists again see inside and say the length of the bulging of the trachea. You see, this is the left bronchus. We are on the back wall of the trachea in the carina. These are my hands. So left bronchus, right bronchus is over here in front. Obviously, the patient is lateral, completely lateral position. And then you decide where to put the suture. We can discuss about this. Too deep, soft tissue. Where is the plate in between the bones? And here you are in the mucosa. So the endoscopist says no, outside the mucosa, but have to keep big bite. So big bite, but outside the mucosa. And another question is which thread, reabsorbable or not. I use a single filament because I can sleep very well, so I can do a sleeping knot adaptation like this one. So the sleeping knot, and then you decide how many sutures. And you can also fix the bronchus to the spina. The problem, if you have a bronchomalacia, the problem is that you fix the bronchus to the spina, you can create an angle. So I don't enjoy to put the sutures in the bronchus. Remember, this is a 15 kilogram, and the tip of the instrument is 1 millimeter. So the bronchus, I think, is 3 millimeters. Very easy to get angle and create an obstruction. So I think if you utilize the back wall, the trachea is probably better than to do bronchopax. We did here. That is a bronchus. Because the anesthesiologist said, collapse, do again. You see the esophagus is around. So the question is, what happened to the esophagus after this? It's failure. I don't know what. Really afraid of this, but we published also a few cases. I let you see now the, I don't know, we have other videos before the standard lecture. Yeah, I want to see again. Oh yeah, I let you see, not trachea, but the abdomen. We do cancer, we do cancer of kidney. So we do a lot of vascular management. This is not for cancer, but this is for stenosis of the renal artery. The endovascular radiologist stand dilated, but was not sufficient because of fibrosis extrarenal. So the patient was very thin or not big, so there was not space to do an auto transplant. So we decided to free completely the renal pedicle because of high pressure and the risk of death. So this is capabilities. So in our learning curve, our learning curve depend also a lot from overall surgery, not only chest surgery. And this is what I suggest to a pediatric surgeon who want to perform pediatric robotic surgeries, to work with adult surgeons in children and do everything, because this is, in my opinion, my training program better than others. I think I finished this part of a presentation, and we go just a little about economy, and after I speak rapidly about thoracoscopy of tracheomalacia. You need collaboration. We had a lot of coordinators, high performance surgical teams, how to build it, and the advancing robotic surgery team to build the group. So we have a fellowship program, and I am a coordinator because I have experience, but everyone can come in Europe and outside Europe countries. And this is a fellowship program. The other aspect is about economy. And if you want to start with a robotic program, you need to have a learning curve. I suggest to have an expert adult surgeon, and then speak about money. And we think that, and I finish and I move to tracheomalacia. First, we demonstrated clinical impact is better for the patient. Yes. Second, economic impact. You need money to do it, and charity at the beginning, but after, the minister pay for everything. And third, ethic and social. Everyone want to come in a hospital that have a robot because it's better for the patient. So I suggest you to think with your general direction, to think that robotic surgery is better than open. Now I move to the chapter you invited speaker is tracheomalacia. Thank you very much to everyone. Dr. Torre, Professor Torre is the expert in my hospital. So this is a presentation he gave me, and he is one of international member of the Society of Trachea Surgery. He is married with a Chilena, so he is frequently in South America, and a lot of experts in trachea come from Argentina, Chile, and Brazil. So thank you very much. I don't teach you what is tracheomalacia. You know exactly what it is, so I don't speak about it. But in children, we were trained by Mounier, Philippe Mounier, that was a Swiss surgeon. So everything that comes from his experience. I don't want to say you what is tracheomalacia. We know that many times you don't need the surgery, so it's infrequent surgery. So we have to collect all the cases. In Genova, in Italy, it's the single hospital that do surgery of the trachea, so major surgery. We know that we do many times orthopexy. You do a minimal sternum resection. You keep the thymus out, and sometimes it's sufficient, or you grab the aorta and fix it, the sternum. So grab the aorta, keep it up. You remove the teeth, you have space, keep the aorta up, and the trachea come up and become large. So generally, this is done by cardiosurgeons. So we work together, cardiosurgeons. If not sufficient, we fix the aorta, fix the trachea on the spine. So you have two routes, anterior part, probably the thymus resection is sufficient sometimes, fix the aorta to the sternum, or when it does not work, fix the trachea on the spine. Many times you could do stenting or tracheotomy, but they are very complex cases. You saw the trachea, the big trachea that is need a resection. So I don't speak about resection because it's not my presentation. Tracheomalacia can cause because by esophageal bulging after TF repair, by vascular ring. You know that vascular ring is a major cause of tracheomalacia, of type of coughing, because of bulging in the lumen. So obviously, that is a surgical, a cardiosurgeon procedure. You see, trachea is easily seen by CAT scan. So you see the vasculature for surgery. Anterior orthopexy is this approach. You keep the sternum out, and then you grab the aorta, and you fix the aorta to the sternum. Can happen. Needle enter the aorta. Not nice. You have, like my first stupid day, you have a lot of bloody. So we do with the cardiosurgeon. You see here, this is a simple example. Sternotomy, open the sternum. We do this also when we do a esophageal substitution, when we cannot enter in the posterior diastole because of the reason, and we ask the cardiosurgeon to keep the thymus out, so we have more space for the new channel, because we are afraid to compress the tract. So when we keep the colon, generally we use the colon, the retrosternal route, we ask to remove the thymus. This is a very, very easy procedure for cardiosurgeon, also for us, but we prefer to speak in this area with the cardiosurgeon. You see, find the aorta, and you put the suture on the wall, and then you fix that in the bone, and the anesthesiologist says yes or not. In our experiences, the anesthesiologist and pulmonologist will help us to see what happened. Michele Torre published with some other international expert. Elliot comes from Boston Children's Hospital, so he is very expert on this kind of surgery. I'm a little in robotic. Vascular anomalies, and want to bore you. See that tracheomalacia comes from vascular problems, from esophageal problem, and we try to study this area. Sorry. Okay, and I let you see simply the anatomy. I don't want to bore you, and you see that the cardiosurgeon do procedure, not us. So for cardiovascular, for trachea, for tracheal compression and the vascular anomalies is impossible to do without a cardiosurgeon. So this is why many of these procedures are done by a cardiosurgeon, not by pediatric one. So you see, this is the notic area, and you how to fix it. Many times the tract is easier to handle than the vasculature. Let you see some more detail. This is Torre, he is the surgeon, and the resection and the sleeve, like the one in robotic, but different indication and done front. So first trachea and then cardiovascular reconstruction. So I don't want to bore you of what I'm not expert. Tracheomalacia, not vascular, so posterior intrusion. That is our chimp. And you see what happened. Patient breath. We are speaking about children, so they have to grow. When you have a increase of CO2 because of obstruction, you have problem with growing, with eating, with social activity, with other neurological aspects. So obviously that we don't want to operate them because we are not sure that surgery can release the symptoms. Sometimes it's caused by the esophagus because you have a stricture of the anastomosis. So you have to face with the GI tract expert, dilate the esophagus, wait, or create a space in front, keep the thymus out, or fix the trachea to the spine. When you fix the trachea to the spine and you have an esophagus, that is a problem because you can cause esophageal problems. So indication is not so easy. So Michele Torre is the center, so he discussed a lot about this. I'm the surgeon, but he is the expert because of robotics. You see, this is tracheomalacia. So we fix to the spine. This is what Michele Torre learned in Boston. In Boston, they started, so they started to suggest this procedure. And now we started with the robotic approach. Open, or robotic. We pass through standard thoracoscopic, but we prefer standard robotic. You see? After TF repair, you see scars here in midline, dissection, and you follow the same plane. There are adhesions. You see that is not a free tissue. When you open a chest and you do thoracoscopy, as you open the pleura, gas creates a plane, and you see the aorta, you see the esophagus, you see the trachea immediately. And when you do a secondary procedure, gas do not dissect, so you have to follow. This is another case we see. I think it's easier and better than open. This was an open approach for TF repair. We have a very few primary case of the TF, but we have not of secondary complication of the trachea of the esophagus. So we have a population that is not standard. The aorta, I look always for the aorta, and then you feel completely the esophagus. You see here there is something, probably is a node or and you see the esophagus is free, and then you decide what is this. This is a foregut remnant. I don't know where the valgus is. I hope not to cut the vagal nerve. Something happened. We do you see, this is a remnant. You see the suture, previous suture? I don't know what it was. A foregut cyst. And then you do your tracheopexy. And where you put the sutures is exactly as the same previous one. You see here, you have the endoscopists that allow you to understand, no, not here. This is a suture inside. Keep it out. You see this? Or this is the fistula. Ah, okay, no, sorry. It is the hole, the fistula. Oh, okay, you can give it. So it's very interesting, the dialogue between anesthesiologist and surgeon. Every minute, we are afraid to do error, and they are afraid of the surgeon, always. So it's very interesting. You see, the lung is not inside the field. It's not a single lumen ventilation, because if you have a bronchial blocker or something else, you have no space, because these are very small patients. So we want the trachea ventilated, and we use gas inside, no accessory ports, gas inside, like for other procedures, and the lung collapse slowly, thanks to the anesthesiologist. So it's very interesting how can they do it. Thoracotomy, open, video-assisted thoracoscopy, or robotic-assisted. And we try to understand. Robotic, 17 patient. Thoracoscopic, 4, 2 open. Why open? I don't know. At the beginning. Or now, but this is not our publication, because you have the esophagus for other reason. TF repair open. Sometimes we do open, obviously. And then you do tracheopexy. I'm not sure that is indicated. These are numbers. I let you see my personal experience, my hands. tracheopexy, bronchopexy, I don't know if necessary. You see that the complete resolution, robotic is better than VATS and is better than open, but not always is good. Why this? I think that in my hands, I can put the sutures better and longer, proximal and distal, because when you work with a standard thoracoscopy, you have a straight line. So it's very difficult to go up and down. In robot, we know that we move our tip of hands, so it's like open, so you can enter everywhere. So I think when you suture is better. As you see, this is the esophagus, twisted, and with a complication. So we had a complication, obviously. This is a leak. Tracheopexy, pre and post. I let you see only the good results, obviously. Sorry. And about clinical cough, okay, no more. We published this. You see, there is no more my name because I'm the chief and I'm not more involved in this kind. Sorry, I don't find. Okay. I'm no more involved in this kind of a surgery because I teach to the young, and it is correct that all surgeons stop working. And these are our details, pre and post. And I think is enough. Obviously, you can have also bad results in trachea surgery, and we need stent, but stent is a failure in children, so never put a stent. Never put a stent. This is not my chapter, so in some case of tracheomalacia, you can do resection, so not tracheopexy, but dilation, resection, but this is not my experience, so I don't speak about the trachea surgery because Professor Torre is the expert, and is a very difficult case, and collecting cases for trachea resection in children. Thank you very much. Genova is an airport. Genova is one of the town close to Portofino Mountain, because does not exist. Yes, exists the city Portofino. And I hope to work with people around the world to share experience, because I'm sure that work together is better than work alone. Thank you very much. Get out later. Switch it off.
Thank you, Professor Matiolli. It's now my pleasure to introduce Dr. Rodrigo Caetano, a faculty member at the Federal University of São Paulo and a leading specialist in tracheal surgery. It is a pleasure to have you with us today, and we look forward to hearing about your experience. Dr. Rodrigo, the stage is yours.
Alô? 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 Antes de iniciar, Boa tarde a todos. Meu nome é Rodrigo Caetano de Souza. Eu vou falar em português porque meu inglês não é bom. I'm sorry, Dr. Matiolli. Probably you understand better in Portuguese than my English. esta apresentação ela está no mesmo horário da nossa reunião de via aérea. Vocês podem ver aqui, nós temos um grupo de via aérea que foi estimulado pelo Dr. João Alessio. A gente está começando esse grupo, está numa fase inicial, média, e algumas pessoas presentes aqui, como alunos, como o professor Saad, como o professor Fábio Marioni, que participa em toda a reunião, como o professor Júdice, que talvez esteja online, o ilustre professor Júdice, participa da nossa reunião toda quinta-feira, Dr. Saad, lá do Rio de Janeiro. Outras pessoas no Brasil inteiro, o Roger, não sei se ele está presente, não consigo ter acesso a isso, lá no Pará, outros colegas em Maceió, colegas em João Pessoa. Então, é uma reunião aberta para cirurgiões, né, para médicos, obviamente. Então, eu quero agradecer a essas pessoas que ajudam a construir essa reunião. Essa hora era para estar acabando a reunião, não gosto de passar da reunião, são próximos 18 horas, então a gente vai passar desse horário. Mas eu quero agradecer outras pessoas especiais, professores que ajudaram a construir a cirurgia torácica de São Paulo, o professor Saad, professor emérito de cirurgia torácica, de cirurgia, né, da Santa Casa de Misericórdia de São Paulo, o professor José Carlos Batista, que está aqui presente, professor emérito do Departamento de Cirurgia aqui da Escola Paulista de Medicina. Quero agradecer a permissão para esse evento do professor Ramiro, chefe de departamento da cirurgia, e eu não sei se ainda presidente ou, se não, ex-presidente do Colégio Brasileiro de Cirurgiões. Quero agradecer ao vice-diretor do departamento, professor João Alessio, que está aqui presente. Quero agradecer ao professor emérito também aqui presente, o professor Otto. Quero agradecer ao professor que acabou de sair, o professor Herbela. Quero agradecer ao professor Ernesto, chefe da disciplina. Quero agradecer ao professor Bruno, que está aqui presente. Quero agradecer ao doutor Marco, que é também do grupo de via aérea, né? Nós principalmente somos, todos operam, mas principalmente 3, que é o doutor Renato, que opera as crianças, que não está aqui presente porque está numa mega cirurgia aqui na frente, um tumor de pulmão com invasão de vértebra, fazendo uma vertebrectomia, que é das maiores cirurgias de coluna que tem. Então ele não vai ter como vir aqui. Ao chefe do Serviço de Cirurgia Torácica do IANSP, está aqui presente, o professor Dr. Mário Cláudio Gefter, e outros colegas que estão aqui, que eu não vou falar todos. E, obviamente, quero agradecer imensamente ao Dr. Campos, que, vamos dizer assim, permitiu a presença do professor Matiolli aqui na nossa reunião, professor Campos, da cirurgia pediátrica. Colega da doutora Bruna, que grande entusiasta aqui na nossa disciplina, para que essa reunião pudesse acontecer. Muito obrigado, doutora Bruna. Sem você, jamais essa reunião aconteceria. A primeira reunião híbrida online pelo YouTube da nossa disciplina. Falei demais, mas são meus agradecimentos. Desculpe aqueles que eu não citei, não por descaso, mas porque são os mais amigos. Então a gente vai apresentar mais ou menos no modelo que a gente faz um modelo de discussão, mas no caso aqui a gente não vai discutir. A gente vai apresentar, no final, se houver alguma pergunta, ok. Mas eu vou apresentar em português, o Dr. Campos vai traduzir alguma coisa que, porventura, haja dúvida para o Dr. Matiolli. Uma criança de 1 ano, que foi encaminhada para a cirurgia torácica, com história de, já no nascimento, de uma intubação prolongada por 10 dias, por intubação, já logo no nascimento, por 10 dias, e que ela foi referida para a cirurgia torácica através da otorrinolaringologia pediátrica externa, com o diagnóstico de estenose subglótica. Então, ela foi encaminhada para a cirurgia torácica com o diagnóstico de estenose subglótica. E, além disso, ela apresentava também disfagia. Então, ela foi encaminhada para o serviço de cirurgia torácica pediátrica aqui da escola, que é coordenado pelo Dr. Renato Oliveira, que eu já falei que ele não está aqui, com essas anormalidades na broncoscopia. Era uma criança pré-termo, com Apgar 3, 6 e 8, que apresentou 2 paradas com necessidade de reanimação já no nascimento, e que já no nascimento já foi feito o diagnóstico de síndrome de Rubinstein-Taibi, que é essa aumento, alargamento do hálux e do polegar, e, além disso, ela também tinha o síndrome de Vater, que é, no caso dela, né, escoliose, ânus imperfurado, artéria subclávia aberrante, rim único direito e atrofia de membros e polidactilia. De antecedente pré-natal da mãe, hipotireoidismo, insulina dependente, sorologias negativas, tinha um irmão autista e ele fazia uso de, essa criança fazia uso de metametasona, cefalexina profilática e sulfato ferroso. A criança estava numa condição geral boa, reativa, cooperativa, mas com um desenvolvimento de altura e peso bem abaixo do padrão esperado para a idade. Aparelho cardiovascular normal e, mais do aparelho respiratório, ela apresentava roncos e estridor. Roncos e estridor. E apresentava também tiragem intercostal durante a ventilação forçada. De outras alterações, a polidactilia, que eu já falei. Então, aqui só o gráfico mostrando, na linha verde o normal, ela estava abaixo na altura e abaixo no peso. No ecocardiograma, o que já foi citado da subclave esquerda e do forame oval patente, e a veia cava drenando para o seio coronário. Foi realizada uma broncoscopia em janeiro de 2025, onde foi visualizada uma diminuição de calibre da traqueia em que não permitiu-se a passagem de um aparelho de 4 milímetros. Então, havia essa diminuição e não foi possível a passagem desse aparelho. Essa é a tomografia dessa época. É um filme. Aqui na tomografia a gente vai conseguir ver claramente a subclávia retroesofágica, áreas de atelectasia, aqui essa imagem de renderização, onde a gente vê essa diminuição de calibre do terço médio distal da traqueia. As pessoas gostam dessa imagem de renderização. Eu não sou apaixonado por ela, eu falo isso várias vezes, mas todo mundo é apaixonado nessa imagem. A angiografia, então, esse seria o laudo, então, o laudo resumido da tomografia, mostrando essa artéria subclávia anômala retroesofágica, também um divertículo de Comerel, suspeitando que esse divertículo fosse a causa também associada à artéria subclávia dessa compressão esofágica. Havia ainda a derivação da veia jugular interna para o seio coronário. Uma outra broncoscopia em agosto de 2025. Eu vou acelerar a broncoscopia. Somente nessa terceira broncoscopia, então ele realizou 2 broncoscopias, cujo laudo foi só desse estreitamento do terço médio distal. Somente então nessa terceira broncoscopia que foi, vamos dizer, diagnosticado esses anéis traqueais completos. Então era uma criança com anel, além das outras malformações dela, ela possuía anéis traqueais completos. Como ela não ganhava peso, como ela não conseguia deglutir adequadamente, porque ela tinha muita disfagia, foi realizada uma endoscopia com passagem de sonda nasoenteral. Essa foi uma tomografia que foi feita antes da cirurgia proposta, que obviamente vocês já sabem que cirurgia é. Talvez os alunos não saibam que cirurgia é, mas é uma cirurgia interessante, não é frequente, não é comum. Inicialmente, a cirurgia cardíaca iniciou a cirurgia, esternotomia, com fechamento do ducto arterioso patente e a ressecção do ligamento anterior do resquício do arco aórtico, onde, então, verificou-se que não era a artéria subclávia que estava fazendo a compressão na traqueia, mas sim o ducto torácico e esse resquício do arco aórtico. Então, essas estruturas foram ligadas e não foi necessário nenhuma intervenção na subclávia, porque naquele exato momento foi visualizado, foi identificado que esse anel fibrótico é que estava realizando essa compressão na traqueia. Imediatamente antes da cirurgia foi realizada uma broncoscopia, onde o cirurgião pôde ver a área de acometimento, que era praticamente toda a traqueia. Aqui a criança, no momento já da anestesia, em ventilação em máscara. Essa criança apresentava, na ventilação forçada, ela apresentava tiragem de fúrcula e tiragem intercostal. Ela foi entubada com uma sonda 3,5. Aqui, a cirurgia cardíaca realizando a ligadura do ducto arterioso, que no caso era à direita, a comunicação então da aorta do terço distal do arco aórtico com a artéria pulmonar. Aqui a identificação das estruturas, traqueia, tronco braquicefálico arterial, tronco braquicefálico venoso. Foi deixado o átrio já com sutura em bolsa, caso fosse necessário extracorpórea. E aí, então, finalizou-se o tempo da cirurgia cardíaca e foi iniciado o tempo da cirurgia, no caso aqui da cirurgia torácica, então, com a tentativa de ser realizado sem extracorpórea. A cirurgia proposta, então, que seria inicialmente a secção no terço médio da traqueia, conforme a figura clássica nos livros. Foi feita, então, a secção, a gente consegue ver a secção do coto proximal e do coto distal da traqueia. A traqueia, externamente, ela não sugere uma redução importante de calibre, mas quando você abre a traqueia, você percebe que a espessura da parede da traqueia ela é um agravante para a ventilação claramente, e você consegue visualizar, obviamente, quando você abre, o anel completo da traqueia. Então, conforme a figura, foi feita a secção da parede anterior da parte proximal e a secção da parede posterior da parte distal. Aqui fazendo a secção da parte posterior, onde a traqueia está tracionada, a traqueia inferior está tracionada superiormente. Então dá uma impressão estranha que é a parte proximal, mas não é a parte distal. Aqui a traqueia distal canulada. E aqui, feitos os pontos de reparo com prolene para tração da traqueia distal, para que se inicie a sutura. Então, o prolene foi para tração, não foi para sutura, a sutura com PDS, onde é iniciado com uma sutura próximo à carina, dos dois lados, um fio para cada lado, e parte-se, diferentemente do livro, que em sutura feita em ponto separado, foi feita a sutura contínua. conversando com o Renato, ele tem 7 casos, não são todos os casos aqui do hospital, são de 3 hospitais diferentes. Desses 7 pacientes, no início ele fazia ponto separado, ele percebeu que a sutura contínua permitia com que ele fizesse com mais tranquilidade sem extracorpórea, porque não demorava tanto assim para fazer a sutura. Então, antes era ponto separado, agora ponto contínuo com PDS. Desses 7 pacientes, 6 ficaram vivos. O paciente que faleceu era um paciente pré-termo de 750 gramas, que faleceu pouco tempo depois da cirurgia por complicações relacionadas principalmente ao pré-termo. Aqui a finalização da sutura, e aqui o ponto final, onde esse ponto final ele acabou sendo reforçado com o prolene que tinha sido feito de reparo. Né? Uma broncoscopia no final, que eu vou chamar a atenção, vou caminhar também, vou chamar a atenção, vamos ver se eu passei. Não, vai entrar. Então a gente vai conseguir ver exatamente como no livro a visualização endoscópica da parte do terço médio da traqueia. Então, essa parte exatamente igual à do livro. Aqui a criança, já no final da cirurgia, ainda entubada. Essa criança ela foi encaminhada para a UTI, ela apresentou febre no pós-operatório, o dreno mediastinal foi retirado no 6º PO, ela foi estubada no 8º pós-operatório e obteve alta hospitalar com essa radiografia no POI, no primeiro pós-operatório, essa radiografia antes da alta. Ela teve uma boa evolução. A gente tem o vídeo da criança, mas como aparece o rosto, a gente não vai mostrar esse vídeo. Ela, em pouco tempo, ela já começou a ganhar peso e melhorou, segundo o relato da mãe, não só a dispneia, mas também a capacidade de deglutição. Aqui o Dr. Renato, muita gente não conhece ele, a gente vê um pedacinho aqui, mas se ele estivesse aqui, eu garanto para vocês que todos o veriam muito facilmente. Quem conhece sabe o que eu estou querendo dizer. Mais uma vez, muito obrigado a todos pela presença. Obrigado, professora Bruna, pelo estímulo para essa reunião, juntamente, obviamente, com a presença do professor Matiolli e do professor Campos.
Thank you, Professor Matiolli and Dr. Rodrigo Caetano for the beautiful presentations. I would like to say thank you to Ciclomed as well for the financial support in this event. My name is Bruna Brandão. I'm assistant professor of Federal University of São Paulo, and it's my pleasure to share this event's moderation with Dr. Luiz Felipe Campos, Faculty of Santa Casa de Misericórdia of São Paulo, and a pediatric and robotic surgeon. I will invite Dr. Rodrigo, Dr. Girolamo, and Dr. Luiz to sit here in front of everybody, and we will start the discussions. Okay. To everybody that is online, it's possible to send us some questions, okay?
Primeiramente, gostaria de agradecer o convite, o estímulo da Bruna. Para mim é um prazer estar aqui na Escola Paulista de Medicina, aqui por... bom, eu vou ser muito sincero, eu sou porco, eu sou original do HC, então, por muitos anos nós tivemos rivalidade no campo esportivo, mas aqui somos todos amigos, tenho muito grandes amigos aqui, a doutora Bruna é a prova concreta disso, né? Todos aqui são muito queridos. Essas rivalidades ficaram lá para trás. Gostaria de chamar a atenção para essa cirurgia que presenciamos agora, muito bonita, extremamente bem conduzida. É incrível ver um caso de Vacter que não tem atresia de esôfago. Isso é uma coisa incomum para nós, que nós associamos sempre com os cirurgiões pediátricos, a atresia de esôfago, a síndrome de Vacter. Acontece, é incomum, basta ter 3 elementos que a gente já considera como síndrome de Vacter, mas é muito interessante ver este caso. Na traqueia, pois é. Então, tá perfeito. Para a gente que gosta de operar traqueia e da cirurgia torácica, tá ótimo. E agradecer aqui, professor Girolamo, once more, for your contribution, so outstanding videos and performance about trachea and other stuff. Thank you very much once again. And Dr. Bruna, thank you. We are open to discuss.
Alguém tem alguma pergunta para fazer da plateia, aqui presencial? Alguém quer falar alguma coisa, fazer algum comentário? Não? Então eu vou começar. Para o Dr. Rodrigo, eu queria perguntar em quais casos você acha que a ECMO seria essencial e por que vocês tomaram a decisão de não fazer essa cirurgia com extracorpórea desde o início?
Pois é, a gente é muito criticado muitas vezes por isso, porque a gente tende, pelo aprendizado com o Dr. Vicente, de fazer tanto a cirurgia de via aérea e sabe como fica o paciente quando você ventila e para, ventila e para, ventila e para, você sabe que ao longo dos minutos seguintes, esse paciente suporta menos o tempo de apneia. Então, se você for um cirurgião que por algum motivo técnico você começa a ficar lento, você começa a ter dificuldade em finalizar a cirurgia. Então, também por isso, veja que foi feita a bolsa no ato direito, caso precisasse em algum momento que se entrasse não entraria com extracorpórea completa, com necessidade de cardioplegia, mas com certeza com oxigenação de membrana. A gente não tem ECMO para criança aqui no hospital.
Muito bom. E for Dr. Girolamo Matiolli, I would like to understand how steep in the learning curve for robotic posterior tracheopexy, and what are the key technical milestones for achieving proficiency, in your opinion?
I think you have to be a tracheal surgeon first. You have to learn everything and how to do it in open surgery. I think we operated the same patient with the rings, but through robotic and through the chest. So sometimes robotic and open surgery, you have to decide which is the best approach. So for the training is full trained thoracic surgeon, full trained pediatric surgeon, and your learning curve in chest robotic surgery is very difficult. So you need someone with you that is more expert than you in robotic surgery. So share the cases with a full trained robotic surgeon that is adult or not important. So the most important thing is to be a good tracheal surgeon after robotic.
Dr. Matiolli, what's the number of the yarn used to make the PEXI, the polypropylene line? What's the number? The teach 5
or 4, it depends on the size of the patient. For tracheopexy, it's better 4-0 because it's more strong. For anastomosis, you can do 5-0 for the esophagus. In the trachea, we prefer to use a reabsorbable. So monofilament, but not Prolen, but a reabsorbable one.
Okay.
But 4-0 is the good one. I use a 5-0 for the ureter, for the esophagus if needed, if the small patient, but no bigger than 4.
Trachea 4-0.
4-0, yes. Okay.
We have We have a question from chat. Professor Gilson Savaia from PUC of Campinas asking you all the experience about using mesh. Tell us.
Using mesh, he's not here. Professor Mioto, he has done few cases with mesh, but in adults. But I don't know in pediatric if it's yeah, in adults. And he made, I'm not sure, in few patients by robotic. And last year, we were in a Brazilian Congress, and there's a very good surgeon from, I'm not sure, Dallas, and he made about 60 pexes with mesh by year in his hospital, all of them with mesh. Yeah, the results are good, but I understand that they try before use Ypsilon stent to test if the surgery will show a good result. So before the surgery, they usually use Ypsilon stent. It's good to ask this, because I would ask to Dr. Matiolli how do you feel like I will make the surgery, I'm sure it will have a good result. How do you feel this before the surgery?
You are speaking about stenosis or tracheomalacia?
Tracheomalacia.
I think mesh, non-reabsorbable mesh, never in children. Dislocate and create decubitus. I don't suggest to use mesh, never, if you can. And absolutely, we are conservative in primary tracheomalacia, posterior tracheomalacia, because we are not convinced about symptom relapse. So I think you have to wait and see what happens.
Okay.
Never mesh.
Never mesh. No.
No stenting, no stenting, because
there's not it will be, yeah.
No.
But how do you feel? No, this patient, I will make the surgery, and this another patient, no, I will not make the surgery.
Percentage of obstruction, near complete obstruction,
only bronchoscopic and tomography.
Bronchoscopy and symptoms and cough and oxygen problems. So symptoms and bronchoscopy, yes.
Okay.
In primary tracheomalacia, if you have a vasculature or rings or something else,
no, it's different, of course.
Bruno? Yes. Professor Alessio?
Oh, I want to thank you to stay with us. It's a pleasure for us to receive you, and it is good meeting. We are talking before about the use of robot or robotic surgery, good or bad, or cost. And we have we in this group have a big experience in neck surgery of trachea without robot, and no difficult. What do you think is the advantage of robot in this case, in thoracic part or trachea or thoracic trachea or carina? I think will be good to show for us. But in neck, you think is better, or what's the advantage?
Can I complement this question? How has robotic surgery changed your approach to pediatric tracheal reconstruction over these years?
I absolutely agree with you. If you reach the trachea through the neck, do it. It's like a tracheoesophageal fistula, the proximal one through the neck, the distal one through the chest. So I think that robot will let you do thoracic surgery better than open. But the neck is neck. Don't change it. Never. The same ECMO or non-ECMO. If you can do the procedure through the neck without ECMO, neck, always.
Other question is, in a patient, I don't know which age, Dr. Rafa Castillo asking about tracheal lesion of posterior wall, 4 centimeters long, 2 centimeters thin, of esophageal lesion, 4 centimeters lesion in a posterior wall of trachea, and those 2 centimeters of esophageal lesion. From 3 centimeters from carina. What do you measure? Esophageal stent, double stent, surgical correction? I don't know if I understand the question.
I don't know if I understand that it's a damage during intubation. Is this?
I think so. I don't know.
But if there's a esophageal lesion, two lesions, esophageal and trachea, he will certainly need, in my mind, he will probably need ECMO. Why? Because when he put the patient on left side and open the mediastinum, he will not ventilate the patient. And with patient like this, you will insert a bronchocut. It's not comfortable. I don't know if Dr. Gefter had some, there's no way to open the mediastinum with a big lesion with no problem. If there's only, if here, everyone from, I don't know if the question is from a pediatric surgeon or for a thoracic surgeon, everyone knows we show this by Dr. Altair. In many cases, he show it in, I remember the name of the paper. Someone will remember for me. He showed a cervical approach to suture the damage from the neck. So we start doing this, and it has a good result, but without esophageal damage.
Professor Torre in her hospital did one case opening the trachea in front, in child, only child.
It's very difficult to go inside the trachea it's very difficult to go inside the trachea with the optical view and
no, open neck. Neck,
but
open
trachea, open anterior,
yeah. Open trachea, go on the back, suture the esophagus, suture the trachea, the trachea.
No, okay.
Did this.
But this question, I think the lesion is very close to carina.
Yeah,
obviously.
Without esophageal damage, we have videos. You can do it inside with no anterior section of the trachea. It's in adult, I think it's better. I have done 25 years ago with opening the anterior trachea, and the trachea becomes some with Malaysia. With no opening the anterior wall of trachea, of course, is better. It's more difficult, but of course, is better.
Two more questions. One for Dr. Matiolli, I think. It's now post-op. If you observe a residual Malaysia after the surgery, if you can observe a residual from Malaysia, something kind of.
Yes. Yes, if you don't put many stitch proximal and distal, you can really leave some kind of malacia. Yes, can happen. This is the reason why robotic is better than thoracoscopy, and we need endoscopy during the procedure, so you cannot have a tracheal bronchial intubation, but you need the tracheal intubation, and very, very proximal the balloon to the chord.
To Dr. Rodrigo, in the case of leak of the suture of trachea, how can you imagine it?
I didn't show, but we had a video, but we make the presentation shorter, and there was a air leak test in a video, and with no air leak. If there's air leak, of course, I didn't show too, but at the end of section of the distal trachea, you cut the tops of the end of this part, and you can suture over the hole. But this patient didn't need this.
They sense you do the same thing, kind of.
If
If you have not just a leakage, not a complete dehiscence, but a partial dehiscence, you do this.
A dehiscence during the surgery or
No,
after? No, after we haven't this, but this is a big problem, very big problem.
Yes.
This is a very big problem. Yeah, but we didn't have this.
Depend on repercussion. Okay.
Yeah, but we didn't have it. It will be a very big problem, because this we do, of course, many times, the air leak test, of course, to make sure this. Yeah.
Okay. He's talking about with
Dr. Matiolli, you have said that even during the section of the esophageal posterior, it's difficult. You don't use bronchial blocker to collapse the lung. You just make the insufflation of gas. Yes, is this? Okay.
We ask for bronchial blocker only if we operate the parenchyma.
The parenchyma?
Yes. If we operate the
because
mediastinum,
the lung without a blocker, it stays some insufflate.
But for the mediastinum, for neurogenic tumors or trachomalacia, we never, or for the esophagus, we never ask for collapse the lung. Obviously, we have to inflate.
And how is the pressure that you use?
4, 6.
Okay.
But the anesthesiologist must use low pressure, high frequency ventilation.
Okay.
Because when you use the pressure in the pleural cavity, you have 4. So the anesthesiologist pump, but not recruit the lung. So we can collapse, and please don't pump. High frequency, low pressure. And in neonates, because they are very unstable, when we do esophageal atresia thoracoscopically, the pH can drop to 7.2 and something else pH. So they accept to have high CO2 and pH can drop a little. But there are a lot of studies that can do it.
Okay.
In case of we need a bronchial blocker, because we have no double lumen in small patient. And when you enter with a bronchial blocker, you have to enter outside the tracheal tube, not inside, because the tracheal tube is too small. So you cannot use the balloon in the trachea. So tube without balloon, the tracheal tube without balloon.
Yes.
So you increase risky. And when you put the anesthesiologist use this sometimes, and they put the bronchial blocker, and Generally, they use a Fogarty balloon,
Fogarty.
Fogarty endovascular, because they are small.
There's a
Fogarty balloon
I'm not sure, but I think there's a bronchial blocker for pediatric.
Yes, now, but not the good size. Yes, you can have, you cannot. Many times they use bronchial blocker, standard one. Sometimes the Fogarty one.
Because the Fogarty balloon, it's a little strong. Yeah.
Yes, absolutely agree.
Ischemia and lesion.
Absolutely agree with you. So we stop the use or bronchial blocker. So we grow using using inflating pleura without selective intubation. Also, because when you move the patient and you have not a double lumen, because the size of the patient, there is high risk to mobilize the bronchial blocker and create problems. So we prefer to inflate, and we manage the lung without single lung ventilation.
Okay. Okay.
But the anesthesiologist must study with you.
Yeah, I know.
Always.
I know this.
Thank you. I have a last question for all of you. In Latin America, we have a lot of challenges. So if we were starting a pediatric airways reconstruction program today, what would be your top 3 priorities to do it?
Good anesthesiologist team, good surgeons, and for devices for little patients. You can have a robot also if you have luck. Devices for pediatric patients. It causes a little bit trouble for us at Santa Casa, a huge headache sometimes because we don't have this kind of stuff. The little device for little patients.
I don't know for pediatric, Dr. Renato, that has his problem. In adults, we have our problems. And I will say in adults, our patients, of course, I think that the anesthesiologist it's a key piece in this treatment or in this growth, in this treatment, the anesthesiologist bind with inside your program inside, because it's very, very difficult.
For you, Professor, the tripé. But
He's agreed.
he's agreed. Okay.
Monique has the last question, and Dr. João Alessio and Dr. Batista will comment.
Thank you, Bruna, Professor Bruna, Professor Rodrigo, and Campos, and Professor Girolamo. Thank you so much to share with us your experience. It's a pleasure for all of us. Once you decided to perform robotic surgery in kids, what's the major problem and difficult that you need to solve to put arms in the little kids?
I think it's not a problem because we are used to small patients. So don't ask the adult surgeon to let you operate a 3 kilogram or 5 kilogram, because you are more expert than an adult surgeon to put ports. So I suggest to start with standard laparoscopic surgery, and you see that is exactly the same. So when we put the ports, we get in touch. So they 2 centimeters between the port entrance, not exit, entrance. I use always 4 ports. My limit in the abdomen is 5 kilogram, 6 kilogram. And in the abdomen is really difficult to get in conflict. Obviously, you have to move the ports differently compared with adult surgeons. So if you have 4 ports, the distal right one is more distal. The left one is distant. The two in the middle are very close and they move always together. They never triangulate, but they are always parallel. So the scope and right hands move all like this. And the other two ports move like this. So triangulation of the two distal one and parallel the scope and the right side or left side if you prefer. And when you work in the deep pelvis or in the hiatal area, liver area, and you move the tip of the instrument, not the instrument. So you're used to do this in laparoscopy. So you get in and parallel instrument. So more parallel and get in touch. But I suggested to follow a group that are used to use it. So I suggest a fellowship program or also observership program. You have the robot, you are full training surgeon, and you want to start with robotic program in a field, in a chapter, go in the hospital you want to follow. Observership is sufficient. Invite, and I think is the answer to the trachea team that want to start. Invite the expert and get him in your operating theater and work together every time. Collect 5 cases, 10 cases 1 week, 10 cases morning and afternoon, and do together. Because I think when we show our best videos, don't say you the truth. Because the last 700 case and the first case was different. So I suggest you enter in the kitchen and cook together. It's better.
Okay, thank you.
Thank you, Monique. But even when you have very small patients, like 9 months, it's possible to put like 4 trackers, or you put like 3?
I always put 4 ports in all cases because I don't use an accessory port because it's too small. So when I operate, I can say we can stay here for a week, I think. Which are the patients you have to operate robotically under 6 months of age? Obturatory and neurogenic tumor in that area, teratoma in that area, reimplant of the ureter only in case of symptoms, only if you have a big diverticula. So very infrequent reimplant in under 6 months. You do stoma and you wait. Upper, I don't think gastroesophageal reflux because under 6 months is very infrequent. Atresia, I don't do neonatal robotic surgery, no. Biliary tract, yes, megacoledocus. And nothing else, I think. What is? Cancer of the pancreas, you can use it. But which is the frequency of cancer of the pancreas? In the chest, nothing. Also 4. UPJ obstruction, 4 or 3, your choice. But it's so nice, do it.
Does anybody else wants to do it?
No, only a comment about Fogarty. We have here a specialist, a vascular surgeon, he's specialist in Fogarty. But you use in the beginning a lot Fogarty infection disease and lung resection with Professor José Ernesto, is our main surgeon, a good surgeon, but I suffer a lot too, because sometimes the Fogarty get out of the place, but is what we have. Like you said, it's too small. We need this. It's good, but need to pay attention. Put out of the tube, use the balloon to block, to not get out to the place. Have a lot of but is for vascular surgeon, but you need to use sometimes because it's small.
I suggest not to use the Fogarty for as bronchial blocker. Many time, not many time, few time, not one time, our anesthesiologist used the Fogarty to stop the fistula of the esophagus because it was difficult to ventilate the child. So I said, I'm not sure. Yes, I do it. And he put the Fogarty in the stomach through the fistula, then the tracheal tube, then, and in 5 minutes, we had the trachea broken by the Fogarty. So I don't think it's good this instrument and dislocate and break the trachea and do many things. But it's an alternative to the new bronchial blocker. But the question was, do you need to blockade the bronchus in mediastinal surgery? Never. For the lung, we prefer no selective ventilation. The single indication is sarcoma, metastasis from bone sarcoma. But we prefer to handle the lungs, so we do open. So it's very difficult and frequent.
It's because we have here a lot of infection disease. Then the secretion is more. And Professor Otta, your bronchoscopists have a good experience with Fogarty and with all kinds of balloon to block fistula. Bronchial fistula, it shows and have a good experience. I don't know if you want to talk about this, but
in adults. In adults.
In adults.
In adults.
Yeah. I saw this patient 1 week before, having something about the 17 years after the tumor was the epidermoid cancer of the right main bronchus. And then was stage 4. She developed a fistula in this right side. And I put a Fogarty. And after 1 or 2 weeks, she was got out to the hospital, got out. And I advised her, it can move and block the only one bronchus now. So if it happens, you cut the balloon, the catheter. It happened, so. Wow. And I tried to put second time another one. And again, it lost the position, but it was occurred in my view. So I changed have a thoracostomy. I made tunnel with a catheter, making curves to avoid the loss of position. And it was for almost 1 year. I removed it. And Dr. Vicente Forte ordered to open transsternal resection and through the posterior wall and of the pericardium, clamped with the bronchus, right bronchus. But even with it, developed again fistula. So I put again the balloon, and it has, I think, 14 years. I saw her just 1 week now. She's alive. It was a T4. So I believe that the infection increased the defense. So she is alive. Professor Galuti used to say, if you have an MPM after a surgery, it will turn better the defense of the patient. She's alive.
Very good.
I said that he has a good experience.
Yes. So we have to close this event. Thank you so much for everybody. I will invite everybody to take a picture together here. And thank you so much for the presence and the online audience too.
Thank you.
Obrigada, Luiz. Um beijinho. Desliga aqui.
Vocês vão competir, vocês vão competir. X, sabe? Tá aparecendo? Sempre aparece. Eu gosto de silêncio. Instagram. Forza, tutti insieme, avanti. Outra que eu não sei.